everybody. My name is Brandon. As you know, I am the Treatment Health and Wellness Program Coordinator at Positive Living. So thank you all for joining us today for that Lunch and Learn presentation. And this is the BC People with HIV Stigma Index project. First of all, we're going to acknowledge that we are gathered here on unceded Coast Salish territories. And that includes the Musqueam, the Squamish, and the Tsleil-Waututh First Nations. So we're very grateful to be sharing this location. We have ordered a bag lunch for everyone. If you haven't already picked one up, please help yourself. There's a few left over there on the table. I'm going to ask everyone to turn off your cell phones or switch it over to vibrate, just as a courtesy to everyone else around you, and I will do the same. This presentation is being broadcast live as a webinar. So we have about 6 or 8 people that are joining us on webinar. Shafia will be keeping an eye on the webinar people, and she will bring forward any questions from them as well. This is kind of an open presentation, so our lunch and learns typically are open discussion. So Antonio is going to be doing his presentation, which is all prepared. But if you have any questions throughout, please just raise your hand or flag them down. He'll point out the questions as they come. We're very pleased to have the support of our sponsors, and those are Beeve Healthcare, Merck, and Gilead for today's presentation. Everyone should have a copy of our two-sided positive living evaluation. So by the end of this lunch and learn session, if you can all just take a minute to go through this evaluation, let us know what you thought of today's presentation, what we can do to improve our presentations, and if there's anything new, any new information that you think is going to be relevant to be presenting. The lunch and learns are typically presented to frontline service providers, so it's to our peer navigators, to other agencies. And this is a learning opportunity for us when dealing with people living with HIV. So that's the light I hope that you will take with you when you're doing those evaluations. So our presenter today is Antonio Morante. Antonio is with the Pacific AIDS Network. So the PAN organization has graciously agreed to have Antonio come and do this presentation today. Antonio has been involved with Pacific AIDS Network for several years on various levels. He's been a member of the board. He's a peer researcher on the BC People Living with HIV Stigma Index project, and currently he's the knowledge translator for the Stigma Index project. So please welcome from Pacific AIDS Network, Mr. Antonio Morante.
Good afternoon. Thank you very much for being here today, spending some minutes with me. My name is Antonio. I have lived with HIV for 19 years. I started dealing with HIV knowing that my ex-partner died. So that guy was dying, and then I just realized I was positive. And I would say that it was difficult just to manage this journey, starting with death instead of life. And now we have taking the medications, and we can be undetectable virus. We can have undetectable virus, and we cannot transmit virus. So that's a big change for me from facing death and now facing life. Living in Venezuela, where it's my home country, where it's undeveloped country. I went once, and then going to the programs, for the antiretroviral programs, taking that medication, and then realized that there were not enough medication. So the nurse told me, I can give you the heart of the bottle. And so she put the pills in her hands, and I said, don't put the pills on your hands, because I don't know where your hands were before. I know where my hands are, so give the medication to my hands. So that kind of inefficiencies in the health system, I know how it is, and I am blessed to stay here now in Canada, where for me it's a wonderful health system. It's not perfect, but it's much better than we have in many other places in the world. So, the survey for the Stigma Index project was a tool designed for people and by people living with HIV. The tool was, the main point was to gather information from participants about just to talk about their experience when they have, because they were living with HIV, what is the experience they have about discrimination and stigma. And intended to identify areas to detect advocacy and action. We are looking at people, how they are involved in community, how they are doing something more for their health, but also for helping others living with HIV. Has been implemented in 80 countries. It's an international project, and BC is the pioneer in Canada applying this project. We are supporting Manitoba and Ontario because they are studying now. We are sharing our experiences, where we can improve things. And a team of peer research associates gather data from research. So we work collaboratively with multiple teams, and we have needed to deal with time, with patience, flexibility. The researcher, in my case, I would say for me was a good experience. Disclosed my HIV status. People can felt more comfortable sharing their experiences. Was maybe at the very beginning with people I didn't know. They felt uncomfortable talking with a stranger about HIV, their HIV, and then when I disclosed my status, they felt much more comfortable. Because it was an international tool, there are some areas that I think it's need to improve, particularly for gay men. It's not, we realize there are more questions we need to look for, that they are not included in the original study. So it was not a random sample, we need to, so we post our information to recruit participants, and we contact them. It was not randomly, so we just talk to them. We interview 176 participants, and the responses for each patient differ for participants from different areas. I feel completely pictured in this rotation because there was a story with one participant that person was very felt guilty, I would say, or she was very shy to talk to me. So I need to talk to one social worker at ABI in Vancouver Island, in Victoria, and then the lady was repeating exactly the same words for each question, and the lady who we were interviewing just saying answer for that lady, not for me. But that was the way she expressed, so I just said, I am in the same boat you are, I am HIV positive, and then she started to talk to me. So I would say she felt much more comfortable when I just say I am living your same experiences. So from this study, majority of men were interviewed. Maybe we need more women. Maybe this is the amount of women we require, maybe more. In this survey, for those living with hepatitis C, it's great that we have 16% of them that were treated for hepatitis C. The age range, well, maybe between 30 and 49 was the main group of people that we interviewed. And the time living with HIV is 10 to 14 is the majority, 35%. So the study of the, as I mentioned before, the core process was just to talk to them about their experiences, about discrimination and stigma because they are living with HIV. So even we were talking in the time frame, we were talking in the past 12 months. The majority of the questions were focused on the 12 past months. There were some questions related to the diagnosis. That was that we needed to say that tool needs to be improved because people felt like I am in this frame time and then this is the other frame time. So we moved in the survey in that way. But the majority of the questions were focused on the last 12 months. The preliminary data is, do you hesitate to test for HIV because fears about how others respond? So 53% they say yes. This is the way that we spread out. They are afraid the police might bring charges for them. They are afraid partners will be physically violent with them. They are afraid of loss, of removal from school. And afraid to be shown by family friends. 71%, which is very high. Was the decision to get tested by you? So even was 73% their decision. There are some other layers that we need to consider that. And we need, that's the one of the points that we are in the process to design qualitative interviews, because it was like a yes or no answer in some questions. We need to gather more information from the no or the yes. In the last 12 months, deciding not to share your status with someone else who supports you, was 33% say yes. Deciding not to attend social gathering, 40% say yes. Isolating yourself, 50% say yes. It's yes or no question, and we need to maybe in the qualitative interviews to talk to them saying, why do you decide to isolate it? So again, was not designed in the original tool. So in the last 1 month, has your HIV status made you feel, sorry, it's not, can you move a little bit more? Great to see that. I felt I should be punished, the first one. I felt suicidal, which is 70%, I think is very high. I blame others, I feel guilty, so, sorry, the last two, I don't know where they are. It's about 60, almost 60%. The last one is a little more than 60%. I have a very low self-esteem, it's more than 60%. Okay. In the last 12 months, have you avoided going to a hospital? 22% say yes. Avoided social services, 23% say yes. In the last 12 months, have you fearful of any of the following things happening to you, whether or not they actually happen? They feel, they fear about that. They never happen, it never happened. 42% are afraid of being physical harassed or threatened. 49% afraid someone who would not want to be sexually intimate because they are HIV positive. And 56% are afraid of being verbally harassed. So, in the last 12 months, have you confronted or educated someone who was stigmatized or discriminated against you? Even if it's just they say 52% they say yes, the remaining 48%, we need to know why they decided not to confront someone. It's because they don't have the education, they fear to disclose their HIV status, and it's because what? We don't know. We need to find out why in that qualitative interview. When asked if they are sexually active, 42% say yes, and we need to know why they are not sexually active. It's because their HIV status, is because they fear to disclose their HIV status, because what reason? Again, just no answers are not the best options in this case, so many cases here. Stigma in communities. Further analysis, we need to ask to talk about denial of health services and dental services, loss of home, loss of employment, loss of education opportunities. The time conference, we just met with different regions in the fall conference, and we talked about 3 main points: community stigma issues, changes needed to empower individuals, and changes needed to improve systems. I am talking here only about Provincial and Fraser. This is what, because we are not going to include the rest of the health authorities. So in Fraser, isolation, they say for Fraser, smaller communities, particular immigrants and MSN, they are isolated. They don't want to talk about sex. They don't want, and particularly for immigrants, just be an immigrant and just talk the cultural part of when we move from one nation to one place to Canada, we just carry out our thoughts, how HIV was in our country. And we are very, we feel sometimes guilt. Sometimes people can feel, they don't feel completely open to disclose their HIV status, and it's okay. But the point is when the immigrant community needs to be educated. That's the point that they mentioned here. So even they say disclosure for sure is more, is easier in bigger communities than smaller ones. It's an issue for many people, how to disclose and why to disclose. And every time has their own speed, their own time to disclose. Then the changes need to empower is support to disclose in safe ways, in safe situations. And I think this is something that we need to talk about, how to improve this disclosing for people, how if they want to disclose, what the reasons are to disclose. Empower HIV in leadership training. So it's one of the other disclosing and training for leadership on HIV is how we can just be part of the process of change. And then increases the awareness about diversity in sexual orientation. So there are people here saying that we need to have more leaders, be a gay man or an HIV positive, disclosing their HIV status. But who is going to do that? Who is going to take that role? We need to train that person. We need to empower that person. We need to provide education for all people. Increase awareness, diversity of population affected by HIV. So they are saying that women have different needs, and particular groups in the HIV population have different needs. Men, women, kids have different needs, different programs, different approaches. For coastal region, disclosure for, even they say here in Vancouver it's easier to live with HIV because disclosure and the acceptance of HIV is more accepted in the rest compared with other regions. And people are just also complaining about how to disclose. And the criminalization is a form of institutionalized discrimination. I agree. So we need to continue working. Science said that we don't transmit the virus. However, there are many social issues around, in particular the law, which forces people to disclose. So there is something here, something allowed to continue working in criminalization. Changes need to empower individuals, live science and skills of new diagnosed people to be more open about their status. I think this part is about education and acceptance. And if we have a better, the point is, if we have a better health using our medications, the best confidence we have with our doctors, we can be more open about our status. I feel healthy. I feel that the way that I'm doing it right now is the right path. So I feel comfortable disclosing. Can change from people to people, how the reason they disclose. The leadership is obvious out. People, peer navigators to support the disclosure. So I would say we need to talk more about, I would say the main topic in all health authorities is disclosing. So this is something we need to continue working on. Why to disclose, why not to disclose, and this is a personal decision. Education of health providers. So there are some stories about the U equals U project, saying that doctors, one person went to the doctor saying, I need that my partner takes PrEP. And the doctor said, no, how are you going to spread your virus? This is the quotation. So there's something we need to educate health providers. So this is stigma in the healthcare. So again, science shows that HIV is not an issue in this moment for transmitted virus, but we need to continue to educate. So the education is continuing. Yes.
Can I just clarify that with, if you're on treatment and undetectable, then it's not an issue for transmission because there's a very low to no risk for transmission. But just to make sure that it's clear that it's...
Yes, if you take the medication and you are undetectable, you don't transmit the virus. This is what science says. Do you have any other questions? Education. So something educate the community, educate the government, educate the healthcare. And gaining support from community leaders, as I said, just having one person taking the role to support campaigns against stigma. So the next piece, what comes next is continue analyzing. There is a team looking for more answers, more results. The findings will continue to be presented to hear from people living with HIV in different regions and communities. We are going to post results. We are going to be to the CAR conference for, this is going to be one of the projects. As community identify their needs, we will provide data to support the development of the tools. So I would say this is something that we are going to continue working, as I mentioned before, about qualitative interviews, taking more information about it.
Is there any documentation that's available for distribution at this point in time?
Well, at this point of time that I have is this presentation and this document, which is the original points every health region said in the fall conference, the topics that I discussed. I'm sorry. I discussed here. So for these topics, so this is a summary of what is here. I can just provide a copy for you.
That'd be great. If you could send it to Brandon and he
This
could
is, but
distribute
it has the whole health authority, so it's 14 pages here.
That's fine. That's fine. Yeah. And the slide deck.
Can we just flip through go back to, I mean, one of the ones that stuck out to me was that 13% or something people were given the HIV test without their knowledge. That concerns me. Doesn't surprise me actually with the stop.
Yes, well, in these cases that we have is just if they have that experience. So we don't know the story behind that.
Right.
We can say I was tested without my consent.
Right. So
Maybe
yeah,
we need to figure it out. So, we need to talk with those people. That's why the qualitative interviews are important, to gather the information from them and say what happened. Yes.
I worked on a project
basically I asked the same because when I was interviewing when I was about to ask
Can you
to
say something?
explain, sorry, to explain like certain things that jumped out at me, I was interested in knowing why. Part of it is related to immigration test, which is regarded as something that warrant in their choice.
Right.
Because it's done automatically once you apply to immigrate to Canada or even have a student visa or a work visa. It's done whether you want to or not. So that was why, to explain like a large part of the 13%.
I want also just to point out something that Asham said. It's about the initiatives to address stigma are involved in your region. So he mentioned about pledge to assist who face discrimination. The second is correct media when you see a chance. So this is our role. This is a ready-made package that can be used as a resource to educate media, a language to be used. So we cannot be silent actors. That's our role. Just don't wait, don't expect that someone do that. We can do it. It's my participation in this process.
Other quick question, sorry, if there any, oh, sorry, go ahead.
What's the difference between the first 2 points? They look the same to me. I mean, I don't know where I fit in there, and I could fit in either or both.
Well, this was maybe just the way that was described, these 2 points in the survey. Yes, I agree. It could be just the same. I was made to the HIV test by someone who forced you, and the person is under pressure. Yes. Remember that this tool we use an international tool, and we developed years ago to apply what was there. Yes?
How many participants did you have?
Well, initially we had 181, but this one we managed the data, and there are 176 surveys, so participants.
That's from the whole entire
For
province?
the whole province.
For the whole province?
Sorry, what was the age? Would we have an age at all, or average age? Is that, like, the question I'm getting at is that stunning thing about the sex.
The
that
age
only
is
less than
here.
half.
What is that? The age is here.
Sorry, just looking at
Here
the drain story.
is the age.
Well, okay, I see.
So between 30 and 49% is 60 something, 60,
So-
73%.
So I would argue that's probably younger than our demographic of HIV at this point in time, but it's concerning to me is that about half the people are not having sex. I'm not saying that old people don't have sex, but I'm just saying I thought, okay, maybe older people aren't having the sex, and but so it's younger people. I mean, that's substantial. 30% of that is 30 to 39, which is, and then half the people are admitting they're not having sex. So that's a startling.
Don't you think that it's interesting, though, Neil, that, we know that there's a large population that's over 50 that's HIV positive,
Yeah.
but really people who are participating in this
Yeah,
are
that's-
younger, right? And so that sort of talks about what those demographics, how active those demographics are, right? 50 pluses have been through this already.
So it'd be interesting to do a comparative because we do know that millennials are having less sex than their older counterparts. Yeah.
Okay.
Yeah.
I'm working on 2 different studies in this, and we've had the same results with that same question on sex. And ours is a little bit higher, but we also brought in criminalization. And we have demographics from 17 to 73. And it is a high number, and when we asked the question why, it was the stigma that came up. It wasn't that they didn't want to have sex, and a lot of the older people also voiced that. But it wasn't, for lack of having a partner, it was a lack of not wanting to try and get one. It was easier not to have sex than to dispose.
Any other question?
Sorry, I haven't known guy. So you're talking about doing some qualitative data follow-up. Like, are you, like, what's the range? How many people are you looking at doing qualitative?
Well, at this moment, we are deciding what questions we are going to
Right.
and who are going to, for the participant who interview in this survey, we are going to talk to them about specific questions.
So was there funding given to do that, like the qualitative data research, or are you going separate on your own?
No, it's going to be part of this study.
Okay.
There were actually some qualitative data that was actually not included there.
Right.
And that was actually more wide open questions,
Mhm.
because remember the survey actually asked about the last 12 months only,
Mhm.
and some incidences of like, say, violence or whatnot took place, say, 5 years prior, not necessarily in the last 12 months. So the last part of the survey, almost half of it is actually like qualitative data, and that's still not to be analyzed, right? Antonio? Yeah, we're still working on that. To analyze all of these findings, which is the 5 or 10 question that we asked at that. At the very end.
There are many other questions that I'm not presenting here. I was just mentioning something when we were talking. The point is that this survey was developed to we used 2 hours to interview participants. Right? We realized that we used not in the interviews, was the preparation for the interview and post-interview for all the administrative things, preparing the documents, sending the documents, paying the honorarium, take the money from banks. So there are many pieces behind that we didn't have at the moment of doing this survey. And we are sharing that stories with Manitoba and Ontario in order that they can figure it out 4 hours preparing to. Yes.
What chance have you got to follow up with the 170-some people?
I'm sorry?
What are the chances you're able to follow up with all of them?
Well, we are not going to talk with the entire 176. We're going to take a sample of them. We're going to take a sample of them and make the qualitative interviews. We're not going to analyze the entire population we interviewed before.
That's not my question. How are you going to get to them? Are they
We're
going to be there? Or are they
well,
gonna be
everybody knows, every peer research
Well,
knows the people they interview in their regions. I know the people I interview in my region, so I can just reach out specific people.
So they were in the consent form. There was actually at the very end, there was a section we all made sure to explain to them if they were interested in follow-up for the survey. They were made to sign an initial for that section specifically, and then we kind of took notes of how we can reach them again.
Thank you.
Yeah.
The point about isolation, I wonder if there was any subsequent, because isolation could sometimes be because of depression, which may or may not be connected to the HIV status, and or energy level, which may or may not be connected to the HIV diagnosis. If that was any follow-up into that.
Well, that we need to know is, for instance, this piece can be analyzed with the group. It's working in the analysis now, and they can make the correlation between one piece to the other. We can do that in the group, in the analysis that they are continue doing, and we can talk to them in the qualitative interviews. There are many other layers that we need to continue looking for data for reasons from this research. I would say this is just the surface of the story. There are many other layers we need to break down, and we don't have the information at this moment, but we are working on that.
On that note, when do we expect to have, maybe not the qualitative data, but all the compiled data that you've done in the interviews so far?
Well, I don't have the time in this
No,
moment.
I'm not saying,
I don't know, but
is it a year away, is it?
no, I would say this year.
Okay, so sometime this year.
This year.
Because you mentioned CAR, are you presenting preliminary results at CAR, is that what you're doing?
We're going to have more data to present at CAR, more than this.
We were also looking at cross-examining what factors affect other factors. So we're looking at like, does the level of income or income security affect your isolation? Having income security can affect like, being able to go out and spend money or like participate in social activities. So we're looking at cross-examining other factors that are related and kind of like can provide better understanding of what's going on. And this is all I think with the University of Victoria, where the principal investigator is helping us with that data. But this is, like Antonio mentioned, it's very preliminary.
And the point here is also that we are going to to talk about we need to find out in this study, we can find out how people living with HIV with different ages have the perspective. For me, for instance, just showing a story about starting with death. The new people, they don't have that story because we have these great treatments now. And what they see about HIV is completely different than expected. Many of us. Yeah. Yes.
Actually, a question would be too, adding to what you were just saying, that some of the freshly diagnosed individuals might not even be participating in places like positive living. They're just at St. Paul's, or EDC, getting information, getting medications, and they just go merrily on their way. So, and hence could end up in isolation even though they have a job or whatever, because they're going through all these other emotions and don't have a support mechanism to try and deal with that. So I wonder if that's going to be coming out of that as well.
Could be, but I think we have an exclusion criteria that you have to be at least living with HIV for a minimum of 1 year. But we wanted to measure if there's any, if you've just been diagnosed and your experience with stigma may not be, it could be there, but I think that was one of the, because we had to follow the international standards like Antonio mentioned, and that was their criteria, that you have to be minimum 1 year living with HIV to participate. So that was one of the limitations. But it's a valid point, yeah, you're right. There's automatic pilot and then we are not really connected with anything.
But not being connected to an HIV organization doesn't necessarily correlate to not being socially isolated. Lots of people can have a social life and just not be interested in an HIV organization.
We've actually asked them with the whole section asking if they were involved with any service provider like ASOs, and also there were a section we asked them, do you know if you encounter any form of discrimination, do you know if there's somebody there to help you?
There was a story.
There was a
story that
the
we
whole
asked
thing.
them. Just mention one case.
Yeah.
What was the issue? Did you help support from an AIDS support or AIDS service organization? And what was the outcome? So we have that story. It's not here, but we have that. There are many other. That's what I'm saying. That we have much more data. It's not here, but this is the preliminary story. Yes.
I'm curious, is there any way to tease out in the analysis? Is there a difference between the type of stigma towards HIV that somebody experiences when they're, say, under 25 versus over 50?
Well, this is that I'm saying, that we can just took different samples for each one of these ages and just look what they said about what the group of the 15 to 25, for instance, just taking from the data we have, and then look for their experience, what they say about stigma and discrimination, or what's the issue they confront, and then analyze for each one of the groups.
That's going on right now?
Yeah.
Okay.
Well, we also asked if your perception of stigma has changed over time, just in general. We've asked that question. We've also asked the question of, do you think, like, say, media or like the news, things in the news make your fear of stigma or make stigma worse or better for you? So we've asked this question, like, just to see like how media even like affect over time, or like if the news stories that are published have an effect on how people perceive stigma.
And they say if the media, do you see this? I think that the question was, do you think media change your or impact your perception about stigma with HIV? Do you think that the media outside is stigmatizing? That's one point. The other is but there are many other parts that we're working on. Particularly for those questions that are open questions, they need to find out how the teams, what we wrote in the interview, what we told very clear. So they need to, that analysis takes more time because there are open questions, and we need to figure it out, what is there, what topics are relevant, in order to analyze for instance.
Is there any room, any information get captured, or is this just off the parameter of what was the parameters of the study? I'm curious about, is the stigma associated with HIV different from disclosure or non-disclosure of your status versus at some point is it your appearance? Is it racial? There's all kinds of other ways that we experience stigma that isn't just about disclosure of our status.
We had that question too. We had questions regarding like, was there any other factor like say racial background, economic background, educational background, or the whole immigration status. We have an entire like question regarding that.
I think that the piece here is only about numeric values, numeric variables that we just are showing you. They are not numeric, that we need to figure it out, this kind of analysis, and it takes more time.
Oh, one more question?
I just noticed on the slide here, the age categories, or not the age categories, the numbers of years living with HIV caps at 24. Is that in consequence of the way the thing was done internationally, or is
No, this is
that's the longest living with HIV person you found?
Yeah. There was a people we interviewed.
Because we also have very limited like interview sites. We were only doing Fraser, Vancouver Coastal, the island, and the north. And we tried to be as diverse as possible. So recruitment, we tried to get as many, like we had kind of a quota for like how many people were interviewed from a certain racial background or economic background, because we tried to be diversified. But ultimately we ended up with, it's very hard to get that kind of ideal distribution, which is mimicking like, the general population.
For instance, in my case, I had one time, JP was our supervisor. He said to me, do not interview more people below 50 years old, because you need to find out this group of people, or this group of income people, because we're just looking at different, as diversity in age, in living with HIV, and income, because they have different perspectives.
No, what piqued my curiosity was 24 years would take it back to more or less just before the emergence of the cocktail.
So, thank you everyone. I'm gonna wrap it up there unless there's any other questions. I think I would like to thank you all. It's a bit of a warm room, so thank you all for being with us. Thank you to Antonio and to Pan for preparing this presentation.